Hello, everyone. Welcome. We're working on getting everyone connected and we'll get started shortly.
Oh, oops, don't do that.
Right. It looks like we are connected and ready to go. So please mute your microphones to avoid any accidental disturbances during our presentation. Thank you for joining South Dakota Project Firstline office hours. Today we are going to talk about the gut. This project is sponsored by the South Dakota Healthcare Associated Infections Antibiotic Resistance Program. Next. My name is Rebecca Syme. I serve as the team lead, and I'm certified in infection prevention in the long-term care setting. Your South Dakota Project Firstline team is employed by the South Dakota Foundation for Medical Care. We present infection prevention training and education through South Dakota Project Firstline. Project Firstline is the CDC's national training collaborative for healthcare infection control. Let's take a moment to allow the rest of the team to introduce themselves.
Hi, everyone. I am Jess Stanko. I'm a program director for the South Dakota Foundation for Medical Care. My background is healthcare and long-term care administration. I'm a registered respiratory therapist and certified for infection prevention in the long-term care setting.
Renee Robbins. I'm a registered respiratory therapist and program manager for South Dakota Foundation for Medical Care. I work with South Dakota Project Firstline, and I also work on dementia dialogues training.
Good morning, everybody. My name is Mindy Hoyer, and I am also a program manager for the South Dakota Foundation for Medical Care. I am one of the team members on the Project Firstline team, and my history, I am a registered nurse and a certified surgical technologist.
All right, next slide, please. Some reminders for the presentation today. Please feel free to ask questions. Simply come off mute or add them to the chat. We encourage you to share success stories or ideas. A recording of today's office hours will be shared afterwards to the South Dakota Project Firstline website, where you can go and view it at any time. Please complete the post-training survey. We appreciate your feedback. Next. This time of year, we gather with family and friends to share meals, memories, gifts, and most of all, germs. Today, we will be discussing the gut, where germs live in the environment, common germs found in the gut, and how we can reduce the risk. Next. We need to know where germs live to stop the spread and protect our residents and patients. A quick review. The gut contains bacteria and yeast, which are part of a healthy immune system. Usually, these germs do not cause illness in healthy people. However, they can cause illness in persons with weakened immune systems. Germs from the gut can easily be spread to healthcare worker hands while performing cares. They can further be spread to other people, surfaces, medical devices, really anything and everything we touch. As infection preventionists, we may not be performing hands-on patient care, but we can still be responsible for spreading germs. For example, we may touch a clipboard, pen, or surface that is contaminated with a germ, and then spread that germ throughout all departments as we round. Next. Germs that live in the gut. Today we will be discussing Escherichia coli, Klebsiella, Candida, and Clostridioides difficile. Next. E. coli bacteria are found in the environment, foods, water, and the intestines of people and animals. Most are harmless and are part of a healthy intestinal tract. They help us digest food, produce vitamins, and protect us from harmful germs. Some make people sick with diarrhea, urinary tract infections, pneumonia, sepsis, and other illnesses. E. coli cause more than 90% of UTIs. There are 6 kinds of E. coli that make us sick. Let's discuss them. Shiga toxin producing E. coli. This type produces Shiga toxins, which can damage the lining of the intestines and blood vessels. It often causes bloody diarrhea and severe stomach cramps. In some cases, it can lead to hemolytic uremic syndrome, a serious complication affecting the kidneys. It is commonly transmitted through contaminated food, like undercooked ground beef or leafy greens, water, or animal contact. Symptoms include severe stomach cramps, diarrhea, often bloody, and vomiting. Symptoms usually start within 3 to 4 days after the swallowing of bacteria. If we think about any of the germs that we're going to talk about today, really how we get sick with them is by swallowing them. Groups most affected are children under 5 and adults 65 and older. Major sources are contaminated food, especially leafy greens and ground beef, unsafe water, animals, especially cattle, their feces and their environment, and feces of an infected person. Infection is more likely in high-income populations. Most people recover without treatment in 5 to 7 days. Some people may develop serious problems like hemolytic uremic syndrome. Enterotoxigenic E. coli. This type produces enterotoxins that stimulate the lining of the intestines, leading to watery diarrhea, often referred to as traveler's diarrhea. It typically infects through contaminated food or water and does not invade intestinal cells. Symptoms include watery diarrhea, stomach cramps, nausea and vomiting, fever, headaches, muscle aches, and bloating. Symptoms usually start 1 to 3 days after exposure and last for 3 to 4 days. Groups most affected are adults 18 to 25 and international travelers. Major sources include eating raw or undercooked meats, or eating something that touched raw or undercooked meats, eating unwashed fruits or vegetables, drinking water or ice, consumption of recreational water from pools, lakes, rivers, contact with infected person or animals, or their feces. Where is infection most likely? Low-income populations. Contact a provider if there is bloody diarrhea or severe stomach cramps. Next. Enteropathogenic E. coli adheres to intestinal cells and disrupts their function, causing watery diarrhea, primarily in young children. It is associated with resource-limited settings and spreads through fecal contamination of food or water. Unlike enterotoxigenic E. coli, pathogenic does not produce toxins. Symptoms include watery diarrhea lasting more than 2 weeks. Sometimes there may be low-grade fever, nausea, and vomiting. Symptoms usually start 9 to 12 hours after exposure. Groups most affected, children under the age of 2. Major source, eating or drinking contaminated food or water, feces of an infected person, or infant formula. Infection is most likely in low-income populations. It's important to be mindful that we do not want to prepare food or drinks, including baby formula, if you are having diarrhea or are sick with enteropathogenic E. coli. Do not drink untreated water or unpasteurized milk. Enteroinvasive E. coli, closely related to Shigella, invades and multiplies within the intestinal epithelial cells, causing inflammation and symptoms such as diarrhea that can sometimes be bloody along with fever. It is less common and primarily spreads through contaminated food or contact with infected feces. Symptoms include watery diarrhea, sometimes bloody, and fever. Symptoms usually start 10 to 18 hours after exposure. Groups most affected are children and international travelers. Major source, feces of infected persons. Infection is most likely in low-income populations. Next, please. Enteroaggregative E. coli, forms biofilms on the intestinal mucosa, creating a stacked brick pattern of adherence. It is associated with persistent diarrhea, particularly in children and immunocompromised patients or residents, and may cause acute diarrhea in travelers. Symptoms include watery diarrhea that often includes mucus and lasts more than 2 weeks, especially in children, sometimes fever and vomiting. Symptoms usually start 8 to 48 hours after exposure. Groups most affected: children and international travelers. Major source: eating or drinking contaminated food or water. Infection is most likely in high all the way to low income populations. Diffusely adherent E. coli adheres to epithelial cells in a diffuse pattern rather than aggregative. Causes diarrhea, especially in children under 5. Symptoms include watery diarrhea. Groups most affected: children, usually 3 to 5 years old. Major source is really uncertain. Infection is most likely in low-income populations. Next, please. Klebsiella is common in the intestines, but it rarely causes infection in healthy individuals. It can also be found in other places, such as the lungs and urine. This bacteria is normally found in human feces. They can cause pneumonia, bloodstream infections, wound or surgical site infections, and meningitis. Some are becoming increasingly resistant to antibiotics. Infections commonly occur among sick patients receiving treatment for other conditions. Risk factors: devices like ventilators, intravenous catheters, and long-course treatment with certain antibiotics. How it spreads: person-to-person contact, which is most common, contact with contaminated water, soil, and equipment, wounds caused by injury or surgery. Treatment includes the use of antibiotics, but some Klebsiella bacteria are resistant to multiple antibiotics. Candida auris is a type of yeast that can cause severe illness. C. auris is commensal of human skin and is found in cooler areas of the body, such as the ear canal. It can colonize the skin, which is most common, gastrointestinal tract, which is less common, urogenital tract, or around medical devices. Colonization can occur without symptoms. Symptoms depend on the type of infection. Some examples include bloodstream infections, wound infections, and ear infections. It is often resistant to antifungal medications. Resistant infection can be difficult and sometimes impossible to treat. Healthy people typically do not get it. Risk factors: breathing tubes, feeding tubes, venous or urinary catheters. How it spreads: those infected and those colonized can spread it onto surfaces and objects like bed rails, doorknobs, blood pressure cuffs. It remains on the patient's skin or body sites for a long time. Whether or not they have symptoms, they are still able to spread it. C. diff is a germ, spore-forming, gram-positive anaerobic bacillus that produces 2 exotoxins, toxin A and toxin B. It can lead to diarrhea and colitis and can be life-threatening. It enters the body through the mouth and starts producing in the small intestine. When the spores reach the large intestine, they release toxins that damage the tissue. It can affect anyone. Most cases are often associated with antibiotic use, hospital stays, and group living situations. Let's talk colonization versus infection. Colonization with C. diff is more common than infection. Studies show there is a higher rate of colonization in geriatrics. Colonized patients do not have disease caused by C. diff and often exhibit no clinical symptoms like diarrhea. Colonized patients do test positive for the C. diff organism or its toxin. Signs and symptoms: diarrhea, fever, stomach pain, loss of appetite, and nausea. Complications include dehydration and colitis. In extreme cases, toxic megacolon, sepsis, and even death. Who is at risk? Those 65 and older, who have had recent hospital or nursing home stays, with weakened immune systems and previous C. diff infection. Spores can live for months, even years, if not properly disinfected. Yes, years. How it spreads: person to person in feces. Inactive spores in the environment are swallowed and cause infection. People are 7 to 10 times more likely to get C. diff while on antibiotics and during the month after antibiotic use. C. diff is estimated to cause almost 500,000 infections in the United States each year. About 1 in 6 patients who get C. diff will get it again in the subsequent 2 to 8 weeks. 1 in 11 people over age 65 diagnosed with a healthcare-associated C. diff infection die within 1 month. Next, please. That was a lot of information. Pooping is part of life, as the Project Firstline infographic says. Let's take this a step further. Diarrhea is liquid stool. We already know stool is full of germs. It is messy. If we think about the setting in the photo, maybe this is the community center where you're celebrating the holidays with your family. It could be the restroom you use all day at work, or maybe it's the restroom you use near the cafeteria where you take your lunch break. One person experiencing diarrhea can contaminate the toilet paper dispenser, the toilet bowl handle, the bathroom stall latch, the soap dispenser, the faucet, and the sink, for example. We can also add aerosolization that occurs when the toilet is flushed. Bioaerosol, which is droplets of water and feces, can cast onto every surface in the stall, including the human. High-velocity toilets create a larger risk. If they do not properly perform hand hygiene, they may further contaminate the door handle, the spoon on the salad bar, the phone, the coffee pot, the pen at the front desk. The risks are unlimited. Best practice is to use soap and water to perform hand hygiene when diarrhea is present. Alcohol-based hand sanitizers are not effective for some bacteria that may be present. Next slide, please. Let's talk toileting, bathing, and laundry tasks. We want to stress to staff that they should assume that diarrhea is infectious. Education and review should include: use gloves when you're working with a patient who has diarrhea. You might also need a gown if there is a risk you could get stool on your clothes if you're helping the patient or resident with personal care or leaning over their bed, for example. Clean your hands immediately before and after interacting with the patient or their environment, and immediately before putting your gloves on and taking your gloves off. Review your policies and education related to diarrhea for toileting, bathing, and laundry. Go out and look to see if these policies and best practices are being followed. Perform audits and focus education. Remember, adherence to hand hygiene is greatly improved by ensuring staff have adequate access to hand hygiene items. Part of your infection prevention program should include hand hygiene surveillance, reviewing supplies and their locations, identifying barriers to use that may exist, working with maintenance to get glove and other PPE holders placed in appropriate locations. Next. Hand hygiene. The best way to decrease the spread of infection is to practice good hand hygiene. We know that contaminated hands are one of the largest contributors of the spread of germs in healthcare and really everywhere. Ensure your IPC plans include hand hygiene audits, annual education and review of your hand hygiene processes and policies. We can post reminders, use recognition programs, really be creative. High-touch surfaces, we can add equipment and devices to this as well. We need standardized cleaning and disinfection practices for all staff. This is especially important for your EVS staff. Some facilities may use EVS contractors. In both cases, you should be asking yourself, who's training them? Is their training adequate? Are they getting continued education? Is this in your IPC program? Are we doing reviews of our chemicals? Can we showcase new products and existing products? For example, post a product of the month flyer by the time clock. Are we ensuring PPE is located at chemical mixing stations and at hoppers if you use them? Are these areas clean, on a cleaning schedule, and well stocked? When members of our team are out in the facilities, This is an area of huge concern. Staff turnover and staffing shortages often leave these professionals highly undertrained and unprepared. For example, when we ask, most EVS staff fail to answer questions related to cleaning specific to C. diff correctly. The first thing we hear from management is, "We just had C. diff infection." That should trigger this thought: what can we do to improve that education and make it more effective? Next. We only have 30 minutes today, but we want to stress the best way to decrease the chance of infection is to practice good hand hygiene. Wash your hands often, especially after using the bathroom, before, during, and after preparing food, after touching feces or garbage, and after contact with animals or their feces. Wear gloves, gowns, and consider face protection when performing cares. Clean and disinfect the patient's or resident's environment and equipment frequently with the correct products. Make sure we are handling, storing, processing, and transporting linens and wastes appropriately. Cook all meats all the way. Keep raw meats away from other foods. Wash all fruits and vegetables. Take these risk areas and review your policies. Go look at what's happening in your facilities. Use audit tools, focus education, survey staff and ask them what they need. Identify your specific strengths and weaknesses and take it one thing at a time. Use that ICAR tool. Model 2 focuses on hand hygiene, 3 on PPE, Model 4 is EVS, 5 disinfection, Model 8 wound care, 9 laundry, and Model 10 antibiotic stewardship. Next, please. What we find most often when talking to IPs is they wear many hats and get limited time to dedicate to infection prevention and their infection prevention programs. We know this is a challenge, so don't reinvent the wheel if you don't have to. Some of you may work for larger employers that provide great pre-made education. Use it. Others may not. Have no fear, CDC Project Firstline has many pre-made education tools. Use them, get creative with them. They're customizable. You can take something that's happening in your facility and customize the education to meet your needs. It may benefit you to pull up your IPC plan and the Project Firstline resource page and align them. Maybe copy and paste aligned existing education right into your IPC plan. Use that ICAR tool again. I can't stress that enough. Use your South Dakota Project Firstline team as well. If there is anything that you need, let us know. If there's something specific, ask us. We're here to help. Next. All right, that was a lot today. Do we have any questions or comments for the team? Feel free to come off mute or put them in the chat. Someone have an outbreak story that they'd like to share, or maybe an incident after Aunt Hilda's Thanksgiving dinner?
Hi, Rebecca. Can you hear me?
Yes.
Okay, I do have a question, or I'm gonna just go. So we have a patient, past tense, with C. difficile. They finished their treatment, their PO Vanco, and waited a couple days, right? The 48-hour window to see if symptoms returned of like diarrhea. And then so my question is, when you talk about reinfecting with C. difficile versus colonization, and it can take, so is there like a guideline that I'm missing as far as this patient had active, was symptomatic with C. diff, then finishes treatment but becomes symptomatic again? I mean, what do you typically see with that? I thought I heard like 2 weeks they could be reinfected. So that's kind of a gray area for me, and I don't know if it can be black and white.
I'm wondering if Jess might have a little more insight for us, or I say we may have to kind of pick that apart a little bit more and work through that.
I would
I mean,
agree. Sorry, go ahead.
I guess I mean I didn't know if that's like kind of left up to the provider to work with ID to see if they're truly reinfected with C. difficile or if they're colonized. And I could be wrong. I don't know.
Sherry, if I can interject. So Molly, are you asking, should they go back into precautions? Or I guess I don't understand what you're actually asking, because they can continue to be colonized and spread those germs everywhere. So once that diarrhea, if it would resurface again, I would definitely put them back into, contact precautions and make sure that the staff are using soap and water for their hand hygiene and bleach for cleaning, because those spores can live a very, very long time. I read a study once, those spores can actually live up to 2 years. They found them in a previous room that somebody had been in. So is that your question? Does that help?
Well, if they're symptomatic again, shouldn't we just do right? Wouldn't we do more than just put them on precautions? That's kind of left, right? We would leave that up to the ID doctor to
Yes.
make that determination, I guess.
Yes, yes. I mean, you can't make that decision, but your staff will have to be aware of all those necessary cleaning practices and all of that. Because ultimately, that is the physician's choice if he's gonna restart, an antibiotic series or not.
Okay. Because they could get reinfected with their own environment, or truly did they fail their first treatment, right? I mean, is it
That is correct.
okay.
I can do some more research on it if you would like. You can just email me too.
Okay, I just I find it hard to say that they reinfected themselves with their environment after 48 hours or 72 hours. But am I wrong to can they infect themselves with their own environment? Again, I mean that's
No,
what
I would think that they're just colonized and it just wasn't completely cleared up. I don't think you can reinfect yourself again.
I agree with Sherry on that. Once infected, it's more than likely it didn't get completely cleared the first time.
Thank you.
And I think then that goes back to, just being aware of, I mean, not necessarily related to that patient, but again, those cleaning and disinfection processes by your EVS staff and even just your employees, and being vigilant on our cleaning processes. Good question.
You can always email me with questions too. I have access to the state epidemiologist if we have more questions too.
I have a question. My name is Peg and I'm from Louisiana. And one of the things that I've been doing, I've been writing a policy for CDF for terminal cleaning as well as daily cleaning. And there's really not a whole lot of information out there, especially for the daily cleaning, or very little on the terminal cleaning. And I was just wondering, maybe in the future, y'all could do a presentation on that. That would be really, really great. And two, um, this is always something I wonder about. So you know how if a lab does the test for CDF and let's say there's no toxin A, there's no toxin B yet, and the patient is asymptomatic, uh, would you keep them on contact isolation?
Not if they're asymptomatic.
But there are positive for CDF, but no toxin A, no toxin B.
Yeah,
'Cause I
because they're
had
not showing positive. They're just colonized at that point.
Okay, because I did not, I had that happen to me and I did not put them in isolation. And I was just crossing my fingers, please, please, Lord, don't let,
Well, the other thing we have to remember in all infections is that best practice, if your gut tells you they need to be in isolation or some kind of precautions, then do it. You're not going to hurt anything by doing it.
Right, right. But could y'all also do the future daily and terminal cleaning for CDF? I would love that.
Yeah, it's definitely something we can look into and explore.
Awesome. Thank you so very much.
All right. Any other questions or comments? This is great. We're chatty today. I like it. All right. We're at time, Renee, so you can skip the next slide. All right. With that, I would like the South Dakota Project Firstline team would like to wish you all a happy holiday season and remind you to wash your hands, encourage others to wash their hands, have those respiratory etiquette items available, wash your fruits and veggies, and cook your meats. Thank you, everyone. Please, please, please take a moment to scan that QR code there and give us some feedback, as well as like Peg chimed in and gave us an idea of something she'd like to see. We would love that. We'd love to provide you things that you are looking for and needing. So take a moment to do that for us, if you will, please. Advance to the next, Renee. Here is the QR code that will take you to the Project Firstline website, the South Dakota Project Firstline website. As you can see, we showcased a couple of the products in Spanish and in English. Germs live in the gut. There are a ton of resources there. So when we talked about using your resources and not reinventing the wheel, maybe pull up the Project Firstline or the CDC Project Firstline, either one, and align those resources with your needs. There's lots of great stuff there. Check it out. With that, I will again say thank you very much for your time and attention today. We appreciate you.
Thanks, everyone.
Thank you.